Hi, good evening, everyone. Welcome to our first inaugural Asia Pacific Glaucoma Society webinar. I'm Dr. Seng Kiong Fang from Kuala Lumpur, Malaysia, and I'm the Secretary General of the Society. Can I have the next slide, please? So you can see in this slide, this is our mission statement, and the webinar is also part of our mission because we want to improve the diagnosis and care of patients with glaucoma in our region. And the history, as you can see there in the slide, and we have been collaborating with the glaucoma specialists in the Asia Pacific region. And next slide, please. And we would like to encourage all of you to join the Asia Pacific Glaucoma Society, mainly because we have been doing a lot of educational resources that is available, and this webinar is one of them. Next slide, please. And information can be available at the APGS Secretariat, at the email address, and also there's our website and QR code. Next. As you all know, because of COVID, we have actually postponed our Asia Pacific Glaucoma Conference to next year, and the dates are 13 to 15 August next year. And we hope that you all can join us at this conference, hopefully when things settle down. Next slide, please. Yeah, so I'd just like to introduce our webinar, which is current concepts in management of primary angle closure disease. And we have 4 renowned speakers from the Asia Pacific region, and all of them are the board members. We do have our president, vice president, treasurer, and committee members presenting. Next slide.
Good evening, everybody.
During the Q&A, we can accept questions via the chat group in the webcast. So you can start to ask your questions, but we will only answer it during the Q&A. So without further ado, I would like to introduce Prof Paul Healey, who will be talking to us on how to diagnose angle closure glaucoma. And he is the current treasurer of Asia Pacific Glaucoma Society, and he'll be giving us a 10-minute presentation. This presentation is actually pre-recorded, so we'll go to the pre-recorded presentation. Paul Healey.
Good evening, everybody. We're going to spend the next 10 minutes discussing how to diagnose angle closure. I have no disclosures for any of the content I'm about to present. We're going to start by discussing what we're going to cover. And really, there are only 3 important points that you need to understand in this area. The first are the disease concepts and the nomenclature, because this is a difficult and sometimes confusing area in angle closure. Second, where the diagnostic difficulties lie. And we're still a long way from the perfect diagnosis for this disease. And third, techniques to improve your accuracy and improve your ability to accurately and reliably diagnose angle closure. The reason the angle closure nomenclature is complicated is because we still don't really understand this disease. We know that there is an entity we call primary angle closure glaucoma, and we define that by the glaucomatous neuropathy occurring coincident with angle closure. And by that logic then, angle closure is the preceding step where the angle has been closed and there's no secondary mechanism present, but there's not yet any glaucomatous damage. The problem really arises at the step before this, what we call primary angle closure suspects or anatomically narrow angles. And there are 2 problems here. First of all, there is some potential overlap between primary angle closure suspects and primary angle closure. And second, the number of people who have anatomically narrow angles or primary angle closure suspects is substantially larger than those who go on to get primary angle closure. So our diagnostic difficulty is going to be around those patients whom we think there may be primary angle closure, or perhaps it's only anatomically narrow angles. So how do we define these three groups? A primary angle closure suspect, or somebody with occludable angles or anatomically narrow angles, is someone where there is apparent iridotrabecular contact in the absence of a raised intraocular pressure or PAS. And the reason I say apparent is that clearly if there was a large amount of iridotrabecular contact, you'd expect to have some physiological effect, such as an increased pressure or some signs of contact, pigment patches, peripheral anterior synec, something like that. The way we clinically defined it really is a lack of visibility of the trabecular meshwork when we do gonioscopy. Primary angle closure, as I said, is a smaller group, but of course a more important group. And they're really defined two ways. The first is very much the same as we might define an angle closure suspect. However, they have an elevated pressure. You might ask, well, perhaps you could just have an ocular hypertensive, also had anatomically narrow angles. That's possible, but it's highly unlikely. So it's reasonable to assume that if you have apparent iridotrabecular contact and you have an elevated pressure, then the iridotrabecular contact is causing that elevated pressure. The second sign, of course, is a peripheral anterior synec, which we regard as never being normal. And that really is much stronger evidence that angle closure has existed at least some time in the past. We have to remember that most primary angle closure is chronic and asymptomatic. So gonioscopy is really a key skill in differentiating this disease from open angle glaucoma. As I said at the start, primary angle closure is the easiest of all the diagnoses because we're focusing on the glaucomatous open neuropathy. But in this context, the gonioscopy makes the diagnosis by showing us what is likely to be more advanced angle closure features given the time it's taken for the glaucomatous damage to occur. What about acute angle closure, you might ask? That doesn't seem to come into the nomenclature. Well, if you think about it carefully, the acuteness of angle closure is actually acute pain and vision loss due to a rise in intraocular pressure. In fact, it's due to a rapid rise in intraocular pressure. Because, of course, we see people with chronic angle closure who may present with pressure in the 30s or 40s with no symptoms at all. So it's not the angle closure that's symptomatic, it's the pressure rise. And an acute presentation, while it is an important clinical entity and needs to be treated urgently, it does not mean that the angle closure disease is acute. If you think about it, it's usually the last, not the first iridotrabecular contact that causes acute angle closure. You have to have closed up the whole angle for the pressure to get that high. And prior to that episode occurring, 90% of the angle may have already been closed from a chronic disease. Probably, and again, we don't clearly understand it, in these patients that present with acute presentation of angle closure, there's often recurrent subclinical episodes of closure with elevated intraocular pressure, which occur prior to the disease presenting at the emergency department. So what are the diagnostic difficulties of angle closure? Well, again, it falls into three different areas. Firstly, how best we should examine the angles to determine whether this iridotrabecular contact exists. Second, what the anatomical findings are that are mechanistically important in angle closure. Because if we understand what's important, then we'll be on the lookout for them and they'll be hopefully easier to spot. And lastly, of course, what about the ancillary tests? There are a number of them now. How important are they in the diagnosis of this disease? So let's first ask the question of how the angle should be examined, and the photograph here gives you a clue. The problem we have is right now, angle closure is a clinical diagnosis. And that's because what defines it, if we go back to that nomenclature, is the relationship between the anterior iris surface and the trabecular meshwork. And this relationship is dynamic and it's affected by the examination, but the only way to clearly see it is to actually visualize it. And of course, because of total internal corneal reflection, the only way we can visualize it is with a gonio lens. And this is often, of course, what we see when we put that gonio lens on. We see a large, thick iris, and we see a illumination beam disappearing over a hill. And we need a number of techniques such as dynamic gonioscopy and indentation gonioscopy, and perhaps using this slit method that you see here, where there is one reflection of there is one point where the two beams that come from the superficial and deep cornea that come to one at the surgical limbus, and then we see the reflection across the iris to tell us where indeed the iris root is. That really gives us some insight into what's going on at the angle. But really the difficulty in angle closure diagnosis is the fact that if the angle is difficult to visualize, it's difficult to make the diagnosis. But of course, by definition, really, an angle closure suspect or case will have an angle that's difficult to assess. So what are the anatomically important findings from a mechanistic point of view? And it's very useful to have a mechanistic idea of angle closure because it helps us know what to look for. So we don't always see the kind of iris bombay that Professor Prin has kindly photographed for us here. However, pupil block mechanisms are clearly one of the major causes. And so looking for things that cause the pupil block as well as the pupil block itself are very important in angle closure. So first of all, of course, there's lens vault. That's how far the lens is sitting forward. In other words, how much the lens is pushing against the pupil in order to create that block. And the second part, of course, of that is how the iris responds. So the iris curvature, which is what is often measured in studies, but really the iris rigidity, in other words, how much it deforms when the pressure builds up in the posterior chamber, is critical. And that's why gonioscopic templates that are detailed, such as the Spaeth grading, call for an analysis of the curvature of the iris. Then we have a large area of angle crowding mechanisms. And they're things like a thick peripheral iris, a plateau iris configuration, which could either be lenticular or because of an anterior ciliary body process or rotated anterior ciliary bodies. And these together create an additional risk factor for narrowness of angles over and above pupil block. And of course will remain even if a successful iridotomy is performed. And lastly, of course, over and above all of those, a small anterior chamber area, volume, width, or depth, all of these measurements are associated with high rates of angle closure. Evidence of iridotrabecular contact is the most important and potentially the easiest way to diagnose angle closure. But often you can't see it very clearly, such as in the photos on the right, until after you've taken the lens out and you can indent. For the photo on the left, which is more typical of an angle closure patient, you see perhaps peripheral anterior synex if you indent hard enough, but certainly pigment patches, which you can see in this case, which give you an idea of repeated iridotrabecular contact in the past. It's a soft sign though, and so you need to make sure that it is a sign that you and your colleagues will all agree are more likely to indicate angle closure than another dispersive disease such as pseudoexfoliation or pigment dispersion. So what about the role of ancillary tests? Well, imaging has come a long way for the anterior segment in the last 10 years, and it does offer us some help. It gives us a cross-sectional view of the anterior chamber, but of course it doesn't clearly show us the trabecular meshwork, and particularly the posterior trabecular meshwork, which is critical in the diagnosis. And this is why we can't really use it for diagnosis. But it does give us a cross-sectional image. It can measure in the dark, and it can show dynamic changes in the iris, which can be very helpful. Lastly, of course, ultrasound can show us something that we can't see clinically, and that's the ciliary body. And that's very useful if we suspect there's going to be anterior ciliary body rotation or ciliary cysts. Provocative tests are also a little limited. They're important if they're positive, but they're poorly specific. So the absence of a positive provocative test does not mean that the angle closure does not exist. And lastly, what techniques can I offer you to improve your accuracy of clinical diagnosis of angle closure? Well, it's actually very simple, and it was the advice given to me by one of my mentors when I started my training. Assess the angle of every patient you see. Do a Van Herrick assessment of peripheral angle width, and every time you do gonioscopy, tonometry on a patient, follow it by gonioscopy using exactly the same technique with a 4-mirror or 1-mirror lens that does not require a contact solution. And after you've seen 500, you'll get an idea of what a normal angle looks like and therefore what an angle closure looks like. Judicious use of ancillary testing, if you have it, can help refine clinical classification, particularly when it comes to ultrasound and the posterior chambers findings. And of course, carefully monitor narrow angles for change. Not just angle closure, of course, after you've performed what you consider adequate treatment, but for anatomically narrow angles, because that's the only way that you're going to really learn when an anatomically narrow angle becomes angle closure. Thanks very much.
Thank you, Paul. Our next speaker is Dr. Vijaya Lingam. She is currently a senior physician at the Glaucoma Services of Vision Research Foundation at Shankar Netale, Chennai, India. She has over 138 publications and is the principal investigator of the Chennai Glaucoma Study. She is a board member of the World Glaucoma Association and also of the Asia Pacific Glaucoma Society. We look forward to her talk on the laser therapy for angle closure. Dr. Vijaya.
At the outset, I would like to thank APGS for arranging this webinar and asking me to speak on laser therapy for primary angle closure disease. Laser iridotomy is the most commonly done laser procedure for angle closure disease. The aim of the treatment is to relieve the pupillary block. The treatment is considered to be quick, relatively painless, relatively safe. Laser iridotomy is the first line of treatment for angle closure disease. With the advent of the good, safe lasers, it was extensively used for all forms of angle closures. But protocols have changed with time due to better understanding of natural history, where not all primary angle closure suspect progress to primary angle closure or primary angle closure glaucoma. In view of this, very select group of people are offered laser iridotomy in case of primary angle closure suspect. Absolute indications are narrow angles in the fellow eye of a person with acute angle closure glaucoma or a confirmed family history of primary angle closure glaucoma. Relative indications are frequent pupillary dilatation, a required condition such as diabetics, or poor access to medical care. What does the literature say about this selective laser option? This is a paper published in Lancet from China, where they have followed up primary angle closure suspects with and without treatment for 72 months. In each group, there were 899 patients, and they have seen 19 treated eyes and 36 untreated eyes developing primary angle closure. The incidence is very low, and they strongly recommended it is not required to do prophylactic laser iridotomy for all primary angle closure suspects. What about the role of laser iridotomy with primary angle closure, where there is evidence of peripheral antisynechia raised IOP? Definitely there is a role for laser iridotomy. Similarly, in primary angle closure glaucoma, where there is a demonstrable functional damage following angle closure, laser iridotomy is definitely indicated. Even though there is specific indication for these two conditions to do laser iridotomy, the debate whether to do iridotomy or remove the lens goes on. What does the literature say? This is a famous paper published in Lancet, where they have randomized primary angle closures and primary angle closure glaucomas to clear lens extraction or laser iridotomy. They found clear lens extraction had better outcomes than the laser iridotomy. Even though their evidence is substantial, I like to be very cautious here. Remember, removal of clear lens is not equal to cataract removal, and these eyes are at a high risk for complications. And also, it is very important to remember one randomized study data cannot be extrapolated to the whole primary angle closure disease. In such a situation, till we gather sufficient data, maybe offering cataract surgery for a significant cataract seen in primary angle closure and primary angle closure glaucoma seems to be a good option. Whenever there is a clear lens, better to do the laser iridotomy in this eyes. Coming to the procedure, the first step is explain to the patient what is the treatment, especially in the asymmetric disease. Treating the normal eye explanation is very important. Also explain possible complication and also possibility of the failure and need for the retreatment. Always constrict the pupil with the pilocarpine. Use of the topical adrenergic agonist helps in reducing the possibility of the IOP spike following the laser iridotomy. It also minimizes the possibility of bleeding at the time of the treatment. What kind of lasers one can use? Most of the times it is done with the YAG laser, but there are people who use both argon and YAG laser as a combined approach to create a laser iridotomy. Whatever laser is used, it is always better to start with the minimum required energy to minimize the chances of laser-induced complications. Few things about the machine. So whenever iridotomy is done, make sure you are using good magnification. This is a picture that shows the Zeiss YAG laser machine. A 12 magnification is recommended here. A word about the focus shift. The machine will have 3 positions, posterior, anterior and zero focus shift. For iridotomy, to get maximum benefit of the delivery onto the iris, it is always recommended to use the zero focus shift. Eyepiece setting is important. Interpupillar distance should be accurate and the refractive error, if any, should be adjusted accordingly. Use of the contact lens such as the Abraham 66 diopter lens is strongly recommended. It helps in concentration of energy at iris level. Lens acts as a heat sink, decreases the corneal burn, acts as a speculum, provides magnification. Suitable site should be located. Traditionally, it is advised to do the laser iridotomy from 11 to 1 o'clock position so that it will be covered by the upper lid. And always look for iris script. When you increase the magnification, identification of the iris script becomes easier. Aiming beam should be focused well for the appropriate delivery of the energy. When the aiming beam is focused well, the 4 dots will become a single circular dot. It may look elliptical in case of significant astigmatism. While doing the laser iridotomy, the machine should be in the standby mode till the laser is focused well. Then the treatment mode should be switched over and the laser will be fired from an angle. The end point is look for gush of pigment-loaded aqueous that comes from the posterior to the anterior chamber. What is criteria for success? Clear visualization of the anterior capsule, deepening of the anterior chamber with widening of the angle, and clear fundal glow through the peripheral iridotomy. Postoperative care consists of topical steroids. Consider prophylactic IOP lowering if required, and IOP should be checked 1 to 2 hours after the laser iridotomy. And post-procedure gonioscopy is mandatory, and there should be evidence of widening of the angle that suggests the benefit of the treatment to the angle closure. Complications are known to happen with the YAG laser iridotomy, even though it is claimed to be a safe procedure. Bleeding is often seen with the YAG laser, and it can be easily managed maintaining a pressure and lens on the eye. Inflammation is managed with the topical steroids. Corneal burn can happen, especially in shallow or very flat anterior chambers. So it is contraindicated in presence of a flat anterior chamber. Glare is a late complication of laser iridotomy, so avoid interpalpebral positioning of the iridotomy. The slide shows a late complication in the form of corneal decompensation. A specular shows abnormal endothelial cells on the specular microscopy. Cataract can be a complication of laser iridotomy if the damage to the lens happens at the time of the procedure. Laser iridotomy can get closed with a clump of the pigment over a period of time. This requires application of 1 or 2 laser shots to disperse the pigment. With the time, iridotomy can get enlarged, especially if it's placed in the interpalpebral aperture. This kind of iridotomy can produce even diplopia. Rarely, the bleeding can be significant. Hyphema may remain for a longer period of time and requires treatment. Similarly, inflammation can be severe, and this may require long-term use of the topical steroids. But this kind of a picture is very rare with a laser iridotomy. In conclusion, laser iridotomy is relatively safe, of proven benefit in angle closure glaucoma and angle closure. Current evidence suggests case-specific approach for primary angle closure suspects. The next procedure is the iridoplasty. It is indicated for specific group of patients, that is unresponsive to angle closure glaucoma, angle closure secondary to non-ophthalmus ciliary body congestion, or lens-related angle closure and plateau iris syndrome. It is and iridoplasty is done with argon laser, where 500 micron spot size, that is a large spot size, is used with exposure time of 0.1 to 0.5 seconds. 200 to 400 milliwatts is the power. Usually 24 to 36 spots are used for 360 degrees. And it is placed in the peripheral part of the iris, close to the iris root at equidistance. The aim is to contract the iris and pull the iris away from the angle. This is an UBM picture that shows plateau iris syndrome, that it did not have benefit of iridotomy. The angle did not open. The same plateau iris, when the iridoplasty was done, you can see the evidence of the widening of the angle. So, laser iridotomy and iridoplasty are the most commonly done laser procedures for angle closure disease. Thank you very much for your.
Thank you, Vijaya, for excellent presentation on laser treatment for angle closure. Right now, it's my honor to introduce Professor Clement Tham. I think who need no introduction. He's a current Vice President of APGS and also Secretary General of Asia Pacific Academy of Ophthalmology, and he's from Chinese University of Hong Kong. And today he'll be talking to us on the logical approach to managing angle closure. Clement?
Good day, ladies and gentlemen. Welcome to this APGS webinar on primary angle closure disease. I'm Clement Tham from the Chinese University of Hong Kong. I'm also the Vice President of Asia Pacific Glaucoma Society. In these 10 minutes, I'll share with you a logical approach for angle closure management, which is based on angle closure type and mechanisms. These are my financial disclosures, and also the funding that has gone into the supporting our research in PACG at the Chinese University of Hong Kong. Now, the word primary in primary angle closure disease usually implies that we are not aware of the underlying causes or mechanisms. And so this can be misleading because we are at least aware of several important mechanisms that lead to angle closure in primary angle closure disease. And these include pupil block, plateau iris syndrome, lens-related mechanism, and also possibly choroidal pressures. Now, in this graph here, I try to represent in 4 different eyes the predisposition to angle closure. So the taller the column, the greater is the risk of angle closure and primary angle closure glaucoma. And these different colors represents the different mechanisms leading to angle closure. You can see that in eye number 3, plateau iris is the main contributing mechanism, whereas in eye number 4, the lens thickness is the main mechanism. So in different eyes, these different mechanisms contribute to different extent. The objective of initial surgery is to remove the greatest chunk or height from the risk column by selecting a procedure or a combination of procedures with the least risk for that particular patient. Now, in the next 2 slides, I'll present to you 2 hypothetical situations, 2 extreme scenarios, and go through step by step with you the decision making. Now, in the first slide here, we have 360 degrees complete appositional angle closure. Under these circumstances, if you can widen the drainage angle, chances are that the aqueous can drain through a reopened trabecular meshwork. And so you may not need additional IOP lowering procedures. So if there is cataract extraction, after cataract extraction, if there is persistent appositional angle closure with plateau iris syndrome, then you may consider argon laser peripheral iridoplasty. If there is no visually significant cataract, then you may perhaps perform laser peripheral iridotomy. And if there is still persistent appositional angle closure with ocular hypertension afterwards, then you will have to decide whether it is plateau iris syndrome or the lens being the main mechanism. If it is PIS, you consider argon laser peripheral iridoplasty. And if it is the lens, then you consider lens extraction. In this second hypothetical situation, we have 360 degrees complete synechial angle closure. Under these circumstances, even if you do something to widen the drainage angle, aqueous may still not be able to access the trabecular meshwork because of peripheral anterior synechia. So in this scenario, if there is visually significant cataract, you may have to consider cataract extraction plus or minus 1 other IOP lowering procedure as listed below. If there is no visually significant cataract, then you have to decide whether the lens is the predominant mechanism. If the lens is the main mechanism, then you would have to perform clear lens extraction plus or minus 1 other IOP lowering surgery, depending on the severity of the glaucoma, depending on the IOP control, and also depending on individual patients as well as surgeon factors. If there is no visually significant cataract and if the lens is deemed not a significant mechanism, then you may perform just one of these IOP lowering procedures, with or without clear lens extraction. Now, how do we decide whether the plateau iris configuration or the lens is the main contributing mechanism in a particular eye? Now, first, let us look at the evidence for plateau iris syndrome. And I think a very important sign is the double hump sign, which you can see during darkroom gonioscopy. And of course, UBM can also help us delineate the anatomical status in the anterior chamber. Now, this is a darkroom gonioscopy, and you can see that no angle structures is visible after laser peripheral iridotomy. And in this situation, when you apply indentation, the trabecular meshwork is now revealed. And so this is a case of appositional angle closure. And with indentation gonioscopy, you will also be able to see what we call a double hump sign. This is the first hump, and then a valley, and then the second hump. The reason for the double hump is because in the peripheral iris is draped over a very prominent and anteriorly positioned ciliary body. And then whereas the anterior or more central iris is draped over the anterior surface of a very prominent, very thick and anteriorly positioned lens. Now, in an eye with plateau iris syndrome, after laser peripheral iridotomy, very often you can see the very prominent ciliary processes through the laser iridotomy. Now, with UBM, in the photo above, you can see a very prominent and anteriorly rotated ciliary body, which is pushing the iris towards the cornea, and thereby the drainage angle is very narrow when the eye is in a light situation. Whereas in the dark situation, when the pupil is dilated, the peripheral iris punch up, and in the same eye, in the same segment of the angle, you can see that the narrow angle is now closed off completely by the peripheral iris. Now, with plateau iris syndrome, argon laser peripheral iridoplasty is a very effective and safe procedure. In this video here, you can see a low power, long duration, and large spot size laser is being applied to the peripheral iris, and thereby inducing contraction of the iris stroma. And with this, you can reopen and a positionally closed drainage angle. It is very important when you perform ALPI to apply the laser spot to as far periphery of the iris as you can. Now, what are the evidence for the lens being the main mechanism? I think the most important evidence comes from slit lamp biomicroscopic examination, and perhaps the most important of these is the central anterior chamber depth. The central anterior chamber depth is the combined effect of both the lens thickness as well as the anterior-posterior position of the lens. And so this is very revealing. If you have a very shallow central anterior chamber depth, it signifies that the lens is an important mechanism leading to angle closure in that particular eye. Apart from the central ACD, we can also look for what I would call the Mount Fujiyama sign, which is revealed here. You can see that the anterior relief of the anatomical structures in the anterior chamber in an eye, when lens is the main mechanism leading to angle closure, the configuration of the iris very much resembles that of a volcano, with the iris draping over the anterior surface of a prominent and thick lens, and the pupil, especially a constricted pupil, looking very much like a crater when you're looking from an angle from the side. Now, this final slide here shows you the clinical outcomes of performing phaco emulsification in eyes with primary angle closure glaucoma. This is a randomized controlled trial at the Chinese University of Hong Kong. The solid line represents those eyes treated with phaco emulsification alone. You can see that with just phaco, we get a very significant IOP reduction, which is well sustained over the course of at least 5 years after surgery. Whereas with combined phacotrabeculectomy, which is represented by the dotted line, you get an even larger reduction in IOP, as well as reduction in the requirement for glaucoma drugs immediately after surgery. And once again, this effect or the difference between the two procedures is well maintained over the course of at least 5 years. But of course, with combined phacotrabeculectomy, the chance and the risk of complications would be significantly higher than with just phaco emulsification alone. So that comes to the end of my very brief lecture today. Thank you very much once again for your time and attention. If you are interested in content such as this, please do be reminded that the Asia Pacific Glaucoma Congress, which is organized by the Asia Pacific Glaucoma Society, will be hosted in Kuala Lumpur, Malaysia next year in August. So please do mark your calendar and come and join us for more contents on glaucoma. Thank you very much once again.
Thank you, Clement, for a very nice presentation on the algorithms for management of angle closure. Our next speaker is none other than Professor Prin Rojanapongpun. He is currently the president of the Asia Pacific Glaucoma Society and serves as the chairman of the Department of Ophthalmology at Chulalongkorn University and hospital consultant at Bumgad International Hospital. Prin has been spearheading the Asia Pacific Glaucoma Society, and we are very happy that he has consented to give a lecture on the minimally invasive glaucoma surgery. So now all forward to Prin for his lecture on MIGS in PACG.
I'm Prin Rojanapongpun from Bangkok. I'm going to share with you the role of MIGS in primary angle closure disease. I have no financial interest in the subject of product discussed in this presentation. This is my hospital in Bangkok. We have to understand that angle closure glaucoma is a surgical disease. And we need either to do the laser or surgical intervention to correct the angle closure mechanisms. Talking about the surgical intervention for medically uncontrolled primary angle closure disease will list from trabeculectomy, lens extraction to psychophotocoagulation. Trabeculectomy is, a classic option, but from its inception, we know this is a surgery that offers a high rate of complications, especially in angle closure. There could be higher risk of filtration failures, childhood AC, malignant glaucoma, and increased cataract, likewise in open angle. So lens extraction with or without corneal synecholysis has been proposed and become popularized, especially after the EAGLE study that popularized the lens extraction among surgeons who see angle closure. And I think when we compare with the combined phago tabeclectomy, in terms of complication, I think based on the randomized control trial from Hong Kong Clement Tham groups, it seemed like combined surgery offer more post-op complication when compared to phago alone. With the introduction of MIGS in our treatment armamentarium surgery, I think the lens extraction is become more popularized because they offer several options. We all understand that MIGS is a micro incision conjunctival sparing, supposed to be minimally traumatic, offer the acceptable efficacy, and also rapid visual recovery, and also high safety profile. And I think safety is a big issue because when we're looking at the MIGS for primary angle closure disease, this could be a minimally invasive options for angle closure. It could add once the angle is widened, and it could be used as earlier because of its safety profile. That could reduce the dependency on medication, cut down the adverse effect compliance issue, and also offer the good quality of life in case that we correct and pick up correctly. So that could potentially restore the physiologic outflow. However, there's no good evidence to justify using MIGS as a routine yet in angle closure glaucoma. We need more randomized control trial to look at MIGS for different stages of angle closure and also different angle closure mechanism. Still lack of publication, lack of standardization, and we still have incomplete knowledge to understand MIGS in various stages of angle closure. But talking about MIGS, there are various options of, the ab-internal trans trabecular surgery, and also the suprachoroidal surgery, as well as the subconjunctival stent that connect the AC to the subconjunctival stent. When we're looking at the angle stent, like eye stent and also the hydrous, I think we still need more evidence on angle closure because they are still lacking. To me, the gel stent, the subconjunctival stent, seem to be very easy to understand. This is a 6 millimeter long stent that can be introduced to the injector, ab internal, or could be ab external as well. And with this is a 45 micron, so a small lumen size could be a safe addition when performed with phago. This case, we just inject that stent. So in terms of surgical time, in terms of complication, it could be safer when compared to conventional tabeclectomy. There are factors that has to be considered to make it work. In terms of patient factors, there are risk of scarring and wound healing. I think it's even more important than standard tabeclectomy. For the surgeon, we need to be a better surgeon in perform this. This is a sample case of 65 years old male who, you look at the conjunctiva, it's quite angry conjunctiva. I did put in the stem implant, and then we have to inject anti-fibrotic agent to make it work. Otherwise, with the healing process, that hyperemia of the blood vessels, we could fail. So basically, we need good conjunctival tenon complex to begin with to combat with the scar formation. For example, this is a standalone case, a 74 years old woman who been diagnosed of chronic angle closure glaucoma. I did the LPI and then go on with SLT. Then after 3 years of follow-up, this is her OCT, see loss in the right eye and their progression after 3 years of follow-up. So we discussed with her that with the fixed combination prostaglandin and beta blocker, her pressure is still 18. And even with the preservative phase and options, try to make the conjunctiva as healthy as possible. So I did the Sense gel implant standalone. She's still phakic. This is her eye at day 2. We inject mitomycin C as well as the Kenacort. And this is day 6. And her pressure is quite nice at 4 and 6. And then this is 6 weeks. Her visual field become better because of the ocular surface is better because we cut down all the medication. And then even at 1 year, her pressure is still single digit at 7, dropped from 18 with prostaglandins and timolol. What amazed me, if you look at her cylindrical power at 2 diopter at 81 degree, at 1 year, still 2 diopter at 79 degree, which is basically unchanged or quite stable. Her keratometric reading is quite stable as well. So what seemed to me is that MIGS in a microstent device could offer better post-op refractive stability. And this is possible for combined phaco with this implant in and offer patient toric IOL or even multifocal IOL in very mild case. This was not the case for filtering surgery like trabeculectomy. Stable refraction is not the case because we produce big breadth, and breadth will affect the corneal curvature. This is, for example, this is a case that I performed phaco expression and at 3 months follow-up, and this is a 1.5 year follow-up. The breadth is nice, but if you look at the cylindrical power change from pre-op 2 diopters 77, it can go to 3.5 diopters and up and down and end up with 1.25 at 42 degrees. So basically we cannot predict what it will be end up, and very difficult to judge the toric IOL or even multifocal toric IOL. Could be very difficult. The K reading could go anywhere. So I think MIGS has offer a great potential when we combine phaco and MIGS in primary angle closure glaucoma. And that changed the way we approach. If you look at a different scenario of primary angle closure disease, with or without cataract surgery, IOP control or not control, it used to be like that. But with MIGS, I think that changed the options and how we approach our surgery and our angle closure. So we now entering an IG era. IG to me is the interventional glaucoma that we can perhaps choose from different mix that can drain aqueous to a different area from trabeculectomy, trabecular meshwork, from suprachoroidal space or subconjunctival space. We have to judge between the risk and benefit ratios and also try to understand more on which may go to which patient. In terms of consideration, to me, I think there are 4 things that we have to consider. The angle and the conjunctiva, how it looks, what is the target pressure that we aim for, and also the visual outcome of that patient that we decide to have which lens or which type of lens, and the economic aspect. For example, if we looking at the target pressure, so we have to ask how long and how low we want to get the pressure down to in that individual patient. And there are different studies showing the different efficacy, IOP, lowering efficacy from different mix. Most of these studies are from open angle, but I think if we have more data and knowledge on angle closure, we will decide a better surgery for our patient. So in conclusion, the role of MIGS in primary angle closure disease, there are lots of potential. If you're looking at the internal trabecular surgery, I think this can be possible if we open up the angle with phago. For the internal subconjunctival surgery, I think when compared to trap, is much easier, less time consuming. Although the IOP lowering could be less effective than trap, and long-term IOP control is not currently offer fewer complications and a lower risk for the patient and also for the surgeon as well. It could be the best option when medication is not appropriate or when surgery is also not appropriate for individual patient. If not, if cost is not an issue, I think MIGS have a great role in primary angle closure disease. Thank you for your attention.
Thank you, Professor Prin, for very nicely highlighting the potential role of MIGS in angle closure glaucoma. Now we are open for questions. So I encourage the audience to post their questions regarding any of the speakers of the webinar. And to start this off, I would like to ask Professor Paul Healey that is gonioscopy mandatory for diagnosis of angle closure, or can ASOCT replace gonioscopy? And the next question is, what is your preferred gonioscope for diagnosis of angle closure? Professor Paul.
Thank you, Tanuj. Well, as I said in my talk, at the moment, angle closure is a clinical diagnosis. And so gonioscopy is absolutely a mandatory skill and is mandatory for the diagnosis of this disease. Remember, there are some things that gonioscopy can show you that the other ancillary technologies can't. And in particular, it's going to be the position precisely of that posterior trabecular meshwork that is draining the aqueous, the presence of PAS, and the relationship of the curvature of the iris as the iris approaches the angle. The ASOCT gives us a very nice cross-sectional image, and it has a great benefit in dynamic examination. For example, you can't do gonioscopy truly in the dark. There's always going to be some light, so you're going to always influence it. Whereas an OCT, you can do in the complete dark. And you can show apposition very nicely with the OCT. But of course, you can't always, in fact, often can't see the trabecular meshwork with the OCT. The ultrasound, as I said, very good to show things happening behind the iris. And we saw some lovely images in Clement's talk of what was going on there. So no, the ancillary technologies are ancillary. They can't replace gonioscopy. And lastly, in terms of which gonioscope is better, what's critical is one that doesn't disturb the eye when you want to examine the eye. So it needs to be one that doesn't need a contact solution, which you can comfortably place against the eye in the same way that you do tonometry. In other words, you can applanate the cornea a tiny bit, but you do not want to indent. And also one which you can then either tilt or indent to do dynamic gonioscopy and to open the angle to look for PAS.
Thank you, Paul. Dr. SK, you can.
Yeah, thank you, Paul. There's one question from the audience from Margaret Pui from Malaysia. Margaret Su, sorry, from Malaysia. It's directed to Dr. Vijaya. You mentioned clear lens extraction is not advisable. What are your experiences and do you foresee complications?
Thank you, SK, and thank you for the question. I posed that question, I said that in relation to support for the clear lens extraction versus the laser iridotomy in the EAGLE study, to highlight the fact that removing the clear lens extraction is not like removing the cataract surgery. So when there is a significant cataract, I suggested consider the cataract extraction for the PAC and PACG. If the lens is clear, still consider laser iridotomy, which is much safer than trying to do a clear lens extraction in PAC or PACG. I still believe that if the lens is clear, better not to go for the surgery. If there is significant cataract, yes, definitely surgery should be offered as a treatment for the PAC and PACG.
Thank you, Dr. Vijaya. Our next question is to Professor Clement Tham, who gave a very nice algorithm for managing angle closure. So Clement, the question is that how do you decide whether to do a phaco alone or to do a phaco trabeclectomy?
Thank you very much for the question, Tanush. I think, first of all, we have to bear in mind the main difference in clinical outcomes of these two procedures. Phaco trabeculectomy gives us additional IOP lowering. It also gives us an additional reduction in the requirement for glaucoma drugs. So these are the main advantages of phaco trabeculectomy over phaco. But then the cost that you are paying is the additional surgical risk, both intraoperatively and also postoperatively. So I think the decision is based on whether the additional risk can be justified by the benefits. So I think in those cases when there's very severe and advanced glaucoma, when you require a substantial reduction in intraocular pressure, or when you need a large reduction in glaucoma drugs, then it may be worth considering phaco trabeculectomy. Furthermore, we also have to consider the tolerance of that particular patient or the particular eye to more major surgery and to the risk of complications. So taking all these into consideration, we should be able to decide for each particular patient which is the better option.
Thank you, Clement. There is one more question for you. You mentioned ALPI for plateau iris, but does lens extraction take care of plateau iris also?
Yes, thanks very much for that excellent question, Tanush. I think theoretically, it depends entirely on the relative proportions of these two mechanisms, the lens and plateau iris being the contributing mechanism to that particular angle closure. But in reality, the decision should be relatively simpler. Say, for example, if there is cataract, I would certainly remove the visually significant cataract first and then reassess the angle. If the angle is still close, then you may consider ALPI if there's a plateau iris component. Whereas if there is no cataract, no visually significant cataract, I probably wouldn't consider clear lens extraction, but rather I treat the plateau iris first. And after that, if the lens is still considered one important component leading to persistent angle closure, then after a very careful discussion with the patient, we might consider clear lens extraction.
Thank you, Clement. We have two questions for Professor Prin. So,
okay.
Professor Prin, what do you feel is there any role of goniosyncylasis when you're doing a phacoemulsification for a lens extraction for angle closure glaucoma?
I think in brief, the goniosyncylasis by its nature is not that reliable procedure because the angle can reclosure again. And based on the study from our Indian colleagues, Rojanapongpun and Tanush group, it has been shown that in chronic angle closure glaucoma, even if you're able to widen the angle and open up the trabecular network, it may not functional. So histopatch has been changed. So to me, goniosyncylasis is reserved to very mild case. If you have a case that, the stage of angle closure glaucoma, or the severity of glaucoma is not too bad, it's not closer for too long, then perhaps if you reopen up the angle, it might work. Otherwise, if we have a moderate or severe case, I think we need to do a more, definite drain. And to me, with the introduction of MIGS, I think I discussed with my patient that if we do something like subconjunctival drainage, it's very easy to understand that it drains the fluid. What I don't know is how long it will work, on how low the pressure can go, but definitely the pressure will go down. So patient has to understand that. And the key for that is safety over efficacy.
Thank you, Prin. So one question for Dr. Vijaya. Is there any current role of pilocarpine therapy for angle closure glaucoma?
It's a wonderful drug, no doubt about it. We have used it for so many years. I do use to constrict the pupil before iridotomy. So that really helps in constricting the pupil, looking at the crypt and using few shots with the YAG laser able to do the iridotomy. I use the pilocarpine for the plateauris syndrome. So I don't do iridoplasty, at least in my hands. I found the iridoplasty effect is kind of a reversible with the time. So because of that, I use pilocarpine once a day at night time just to make the pupil small. This works for the plateauris.
Okay. So I think we'll have one last question for Professor Prin. What is the best MIGS for angle closure glaucoma?
I don't know. If you look at my slide, I think we're still lack of knowledge. There's some kind of incomplete knowledge for which mixed devices will be best for which patient of angle closure, because we know angle closure is a big basket. We're talking about stage of angle closure and also the severity of angle closure and different angle closure mechanisms.
Thank you. So I think we have run out of time and we want to be on schedule. So I would like to thank all the excellent speakers, Professor Prin, Clement, Paul, Dr. Vijaya, and Dr. S.K. Fang, and the MCI for running this fabulous webinar. And just to remind all of you, our next webinar will be in collaboration with the European Glaucoma Society, and that is scheduled for 11th of October. So mark your calendar, 11th October, the next webinar. And I thank the audience and all the speakers for your kind attendance. Thank you and have a nice day.